And good morning, everybody. Thank you for joining us today. My name is Kelly Rudd, and I'm the National Sales and Marketing Manager here at Laerdal. I'm also the moderator for today's webinar. During this session, if you have any questions at all, please send them through the Q&A chat function, and we'll have about 15 minutes at the end of the webinar to go through these with our speaker. All attendees will be muted to minimise background noise. This webinar will be recorded, and everybody will get an email with a link to the recording within the next few days. Today, we are privileged to have Associate Professor KT Waxman with us. KT is from the University of San Francisco and also the Director of the Californian Simulation Alliance, and probably very well known to many of you on the call. During this webinar, KT will be sharing her presentation on using simulation to replace much needed lost clinical experiences due to COVID, focusing particularly on her strategies and recommendations. Thank you so much, KT, for joining us.
Thank you, Kelly. I'm so excited to be here with you. I honestly had hoped that I could be there in person, but these things happen, and so we'll get a rain check and try again next year. But it's great to be able to speak to all of you about this important topic. There's my title. And I have a few learning objectives that I just wanted to throw out to you before we get started. I hope that we will leave being able to discuss strategies to utilize online simulation to meet course objectives, tying that back to the course, articulate the value of simulation, analyze the use of different simulation modalities on online learning, and review simulation regulations in most of the states in the US. Today is a very important day in our history. We have an election that's taken place, and I know that you've been watching it on TV. We still don't know who our president is, and it's going to impact a lot depending on who wins. And I just told Kelly earlier when I signed on that, you know, if I could, I would probably move to Australia or New Zealand at this point. It's embarrassing and it's really hard right now in the US, and we're very divided. But what I want to do is review some of the current regulations in the US relative to clinical simulation as a replacement for the clinical experience, and tell you what's happening around the country and why we're so dysfunctional. I want to talk about ways to move from face-to-face to online learning, and talk through what is online learning. Is it remote? Is it online? Is it distant? Is it virtual? Is it web-based? What are the terms that we're all using? Discuss various strategies to meet objectives and maximize simulation. Understand what's available, and then figure out a plan as we go forward. So before we get started, I think I'm going to start with the first poll, Sophia, if you don't mind. I just want to get a sense of where people are coming from relative to sim. So how long have you been teaching in sim? Is it less than a year? Is it 1 to 5, or is it over 5? So now we're viewing the poll results. So it looks like you've got about 50-50 into the 1 to 5 and the over 5. So that's great. Okay, so that gives us a good mix. Let's get rid of that. Okay, how about the next poll number 2, Sophia? Have you been conducting simulation remotely? See, I use the term remote. That's a safe term because you're not with them, you're remote. But online has its own sort of definition. So for the most part, you have not been conducting simulation remotely. So what happened with us in the US is that within 1 to 2 weeks, all pre-planning for spring of 2020 was what we call topsy-turvy. And we were forced overnight into not going into our sim labs and not conducting sims in the classroom, and being forced to teach remotely via Zoom primarily. And it's remote teaching. It's not online teaching, but it's really trying to take what you've done in the classroom or the sim lab and put it in a remote fashion via Zoom a distance learning module so that they get the same experience. We had some folks that actually sent arms and syringes and suturing or whatever the case may be to the students. And then someone online would show them how to do it, and then they would do it themselves at home. That's one example. We also had a lot of trigger videos. So YouTube has been blowing up recently. I know that the California Simulation Alliance has about 7 videos on YouTube, and we use those all the time to share them on Zoom and then do a debriefing on that with them assigned to roles. And we'll talk more about that. It has to be realistic, adaptive, and flexible. And the students were very anxious, and many of the students are still anxious because it's not the same. We had students who were 30 hours away from completing their registered nurse degree, and were told they could not go back into the hospital for those hours. And we pleaded with our governor, we pleaded with our board of nursing to allow us to do this remote learning, and they said no. They said no, no, no. So we were concerned that our students would not graduate, and we begged for clinical sites. We got a few sites in some clinics and some public health sites to get them those hours, but we were forced to move online. And the California Simulation Alliance and Health Impact actually led the cause in Sacramento, our state capital, to get a waiver, an emergency waiver, to allow us to use 50% simulation in replacing clinical hours. And we just passed a law. It was a bill that was passed that allows us to use up to 75% during the pandemic. Okay, so it's in law that anytime we're in a crisis and we can't get a clinical placement in a hospital or a health system, that we can use simulation, and we can use online or we can use in person. So we had to be very patient, and we had to move quickly. Many clinical sites dismiss students while they strive to manage the pandemic. They actually sent letters out effective immediately: no students can come to our hospital. Faculty were charged with creating meaningful learning virtually. And it's important to engage learners in strategies for clinical reasoning. It's not just about the task, it's about really clinical reasoning, critical thinking. How do they do, and how do you evaluate that? Understand the transference of case to online does not equate to virtual simulation. You must do more. And a lot of people were saying VR, it's virtual reality. Well, it's really not. It's distance learning. And hands-on learning is important, and it's hard to do that virtually. So this is the change in the paradigm that we experienced. So faculty are the designers of educational offerings. And so overnight we had to move into this new model. Many faculty actually resigned. They said, we can't do this. I can't do it. I'm quitting. They left. Students got angry. And actually at my school, University of San Francisco, we have a class action lawsuit from our students who say we're paying to be sitting in the classroom, we're paying to go into sim, we're paying to go into the clinical, and you're not providing that, so we want a refund. We don't want to pay this top dollar for tuition. And a lot of the students and the parents got together and have done this. So it's very disturbing right now. We were able to open up our sim lab a couple of months ago, probably at the very end of May, and set up a social distancing area so that they could do their skills lab things in a distanced area. But that made a lot of faculty angry, especially when they were maybe over 60 and they thought that they were more vulnerable. We have since figured this out, but it was very, very tense over the summer. So some creative interactive strategies are really to start with the objectives of each encounter. And remember, when we write a scenario, we have to make sure we have clear learning objectives. And when we do our sim, we have to make sure that those objectives are clear and that that's what the sim is all about, rather than going off in a detour. We had one faculty recently that actually set up her garage where her car used to be, with her daughter as a standardized patient, with all the students zoomed in to do a sim, and then they debriefed it. So people are getting very creative. But we want everyone to make sure they refer to the Anaxel standards of best practice. many of these faculty that have been forced into sim overnight have never been trained. And so we trained quite a few people for free. We decided, let's just give back and make sure that everyone is safe in doing sim and debriefing. And so we offered a multitude of courses on the pedagogy of simulation, how to use a trigger video, how to debrief it, how to do a pre-brief, how to use breakout rooms, all those things. And we gave that away for free until mid-May, and then we started charging because we have to have revenue. So this pre-work to give them ahead of time, asynchronous or asynchronous pre-brief, activities with a scenario, trigger video perhaps, or a standardized patient, and then the whole reflection with debriefing. Doing that online is different than doing it in person, and so a lot of training had to be done. But we always refer people back to the INACSL standards. Include a powerful springboard to immerse students in learning, a video or a story, tell them a story, show them something to keep them interested and interactive. Conduct synchronous debriefing with faculty as clinical expert. And you may have to have two faculty members come in to debrief a sim on Zoom, especially if you're maybe a very skilled facilitator, but you're not a subject matter expert in that particular content. And we want to engage learners to make contextual connections to clinical practice. So we always do like a plus, delta, gamma, what went well, what didn't go so well, and how can you take what you've learned and apply it to practice. We want everyone to document everything they're doing now during the pandemic, because after the dust settles, schools will be accountable to accrediting agencies. And we do not feel, or I'll say it for my personal opinion, I do not feel that we should go back to what we were doing before COVID. I think that we've learned a lot during this time, that programs like a vSim, online learning, is very rich. We've met our objectives, people like it, and why would we go back to doing something that didn't work before? And so we're chronologically writing these things down so that we can then show our accrediting agencies and governments that, hey, this worked, don't make us go back. We're doing 50% sim, and it's working. Our students are graduating, they're taking their tests, they're passing, they're getting jobs. Let's look at outcomes. So discuss the hour substitution with the rationale. Now that's another controversial topic. Does 1 hour of simulation equal 1 hour of clinical? There is a lot of literature out there that says that the simulation experience is much richer than the clinical experience, and some schools are using a 1-to-2 ratio. So 1 hour of sim equals 2 hours of clinical, and there are those out there that are pushing for 3 hours, because we can guarantee a clinical experience in simulation. I want to refer you all to the Healthcare Simulation Dictionary through the Society for Simulation in Healthcare. And when I was president last year, we launched our second edition, and we called out a few specific definitions. Simulation is one, because when you say simulation, what does that mean? Does that mean mannequin-based? Does that mean SP? Does that mean video? What does simulation mean? And that's the other thing that we can defend as healthcare professionals to our accrediting bodies. I can do a role play simulation and I can do a mannequin simulation, but there is a perception that it's all about the mannequin simulation. So there's other things you can do that would be simulation. And then computer-based is the modeling of real-life processes in and inputs and outputs is confined to the computer. You have to have a monitor and a keyboard, but you're immersed. And then simulation-based learning experience, and that definition is there. So all of these things are in our dictionary, and I encourage you, if you haven't already, to download the dictionary. This is the INACSL Standards of Best Practice. So when you're moving to online, virtual, or remote learning, we recommend that you look at simulation design, which is the very first standard. And this will help you create your simulations and design them, whether they're in person or online. So the Clinical Simulation in Nursing is their journal, and the standards of best practice can be downloaded on the INACSL website. So I want to kind of review what's happening in the US. And I know it hasn't happened in Australia, New Zealand yet, but it may. And you may learn from us, or we can learn from you. But currently, every state is different, and that's what's confusing. Anaxel surveyed all the states with a simulation that had a simulation regulation. Some of them don't. Some of them have nothing in writing about simulation at all, and they're all over the map. And additionally, what we found out is there's no consistency in the number of required clinical hours per program. Now, you may have in your states or nationally what the required number of clinical hours are. In California, the minimum hours is 600 for a registered nurse. And we have schools that are doing between 600 and 1,200. So if the regulation reads 25% of clinical hours per course, and you're doing 1,000 hours, that's not the same as 25% of 600 hours. So it's very confusing. We're also having issues from state to state. For instance, if you have a state where your regulation is 50% simulation, and your graduate goes to another state and applies for licensure, and they are at 25% simulation, that's a gap that they may not accept them as a registered nurse because they got 50% simulation and their state requires 25%. So it's very, very all over the map. So some of the gaps that have been identified is the impact on students is significant with COVID. They want to get into the clinical arena and practice their skills. And the hospitals, at least in this area, have said, okay, maybe you could start coming back, but not so many students. We'll just take 4 instead of 8. And they have to bring their own PPE. Or we're going to have them just do med-surg patients, and they're not allowed to take care of any other patients. So it's, again, all over the map, and students are searching for those experiences. Hospitals are eliminating, some hospitals have not come back and said that students can come, and some are limiting the number per unit that they will have in. So we've had to get super creative and put everything online that we can. So here are the regulations by state as of June of 2020, and this is on the Anaxel website. And the regulations read differently in every state. It says up to 50%, and there are 17 states that allow up to 50% simulation. Oregon is an interesting state. They want to move to 49%. I have no idea where they got the 49, but they're also requiring that if you do 49% simulation of your clinical hours, that you have to be CHEESY certified healthcare simulation educator. And that's one of the few states that's requiring that. Up to 30%, we have 2 states, and 25%, 7, which means that the remaining 25 states have no regulation about the use of simulation. So they could theoretically do 100%, or they could do none. Since COVID hit, many states have loosened up their regulations. And there's a couple of websites I'm gonna show you that you can find out what's going on. And again, it's crazy, it's all over the place. But they've loosened up the regulations, said, okay, in PEDS and OB, because we have OB in our curriculum, you can use up to 75%. One state said 100% just to get the hours in sim, and others have said 50% across the board. And these boards don't even know what simulation is. And that is the sad part about this. And they're still in an old mental model that our students need to go into a hospital. And it doesn't say anywhere in the Board of Nursing regulations that it has to be a hospital. It says clinical experience, and it says direct patient care. Now, I know students who have gone into a hospital setting and never touched a patient. So they're there and they check the box that they were there, but in simulation, they can't hide, right? They cannot hide, and they have to touch that mannequin and they have to be involved. So this is all over the map. The National Council of State Boards of Nursing, which is sort of, it's not a governing body, they're an influencer, if you will. They do a lot of research. They did that study about 10 years ago where they did 10%, 25%, and 50% sim. Laerdal co-sponsored that study with Pam Jeffries, Susie Cardinagran, and others. They paid for that, and they monitored it, and they wrote about it, but they can't enforce it. And so my state in California, when I went to the state board pleading that we can increase our simulation and showed them the evidence, they said, well, that's just one study. Give us more evidence. And now I am saying, I'm not giving you any more evidence. We know it works. Snap out of it. And so now we have a bill passed that allows us to do up to 75%. And we're hoping that that will stick. So this is a website, the ncsbn.org/covid19.htm. It gives you a list of everybody, every state in the country, in the US, and where they're at right now relative to SIM. Emergency responses by states and nurses to COVID and the impact on the nursing regulatory bodies. So that's something, I'm not sure what you have in Australia or New Zealand relative to this, but this is sort of the big overseer, if you will, but not governing. So is simulation the answer? Well, if you ask me, I say absolutely. We should be outcome oriented. We should be using simulation. We can guarantee a clinical experience. But we have to still convince some of our stakeholders that it is the right thing to do. So here is another resource list, and it's on the Anaxel website, anaxel.org//COVID, etc. It has press releases, webinars, publications and research articles, virtual curriculum teaching tools, association resources, university resources, corporate, social media, policy change efforts, etc. And you can go to that site and submit your resource for consideration. What happened in the US is everybody right after COVID hit, and I'm talking about mid-March, and I'll always remember that day because that was my daughter's birthday. We were supposed to go to Disneyland. We had the car packed. We were on our way, and we made the call not to go because of what was going on in the media. And then about 4 hours later, they announced that Disneyland was closing. And that was our marker right there. It's like, we got to stop. So that's the day that we pulled together all these resources from all over, many simulation experts, and we all agreed that Anaxel should be the home base to store everything. So the link on the CSA website goes back to the Anaxel website so that it's always updated. And then if you want to submit something, if you have an idea, you can do that by clicking on the click here button. So online simulations, and I'm just going to speak a little bit about vSim right now. And I know that many of you have been using it, and there are lots of other vendors out there that have created these avatars or real people to take students through certain tasks and critical thinking and whatnot. Many of our schools in this country were using that sort of as an add-on. They were doing mannequin-based sim, SPs, clinical, and then these online simulations were sort of nice to have, and they weren't so much, they weren't as popular. Well, overnight, I think that the sales of these products went sky high. And multiple vendors, many being responsive, began offering free or discounted products to just get people to try them. Because remember, this is simulation. And so when the regulators come, you can say, yes, we met our learning objectives through this online simulation. So it's really a search for meaningful interactive activities to engage the learner. Review to see what best fits objectives or of a specific encounter, and build your educational encounter focusing on those objectives, creating these meaningful experiences. So right now, students are very comfortable using online sim. So when this all settles down, are we going to say, oh, we no longer need online sim, we're going to go back over here and do this? No, we need to continue to use it. They like it, it's working, and so we need to make sure we document the progress of these online simulations. And then there's online OSCEs, and an OSCE is an objective structured clinical exam. In the US, we use these for medical school and for our nurse practitioners. I'm not sure how much you're using them here, but the fear was, oh my gosh, it's COVID. we can't do an OSCE. How are we going to go into a room with a patient and do an OSCE? So there is a way to do this virtually. And this reference by Prettyman and Knight talk about how to do it virtually. And what we've seen recently is all the standardized patients that we have been working with are able to come on Zoom. And although the student can't touch them and examine them, they can ask questions, make eye contact, get feedback from that SP, and it's been working really well. So the SPs stopped for a while working, and then all of a sudden we said, oh, can you join the Zoom and be an SP? And so we have been working very much with SPs online. We have a governing body called NOMF, which is the National Organization for Nurse Practitioner Faculty. And this is graduate level education. And there's really, in the Board of Nursing, there's no requirement or governance over graduate clinical education, but this is the governing body. And they say that they need 500 hours of clinical to become a nurse practitioner, and no simulation is allowed. So they are working on this. They have a simulation task force to allow simulation to be utilized within that 500. Many schools right now are using 600 hours, and 100 of it is sim. So they're able, and they're doing research on this to show that if you're using SPs or mannequins in and above the 500, that the students are better prepared to go into the clinic setting. So that's just something to keep an eye on. So questions and thoughts to ponder. When we go onto online sim, we need to ask the question, what are the learning outcomes we want our students to achieve? We shouldn't, be afraid of technology and just make something up. We need to transfer our current course objectives into an online environment and teach and simulate accordingly. And then ask yourself, what's the best modality? Is it a trigger video? And trigger videos are really cool because you can just upload them, click on them, have everyone watch them, assign roles. You do a pre-brief. Hi, this is about a baby with SVT, and it's an interprofessional simulation. And Susie, I want you to play the nurse. And not play the nurse, you are the nurse, you become that nurse, and so you're the pharmacist, you're the doc, and you're the grandmother who is at the bedside. And we'll go through it as if you are that person in this trigger video, and then we're going to debrief it. And this is all done on Zoom, and it's been very effective. I've even checked the pulse rate of some of the students, and the rate goes up when they're watching as if they're in that video or in that scenario. Another thing that we've been seeing in the US is what we call high flex sim, and that's when someone's in the sim center or the sim lab, and they're with maybe another person with a mask on, 6 feet apart, doing a sim, and everyone else is zooming in. And they may have things that they're like moulage or something that they're working with, or they may be doing part of the sim as different roles, and then they debrief. So that's high flex. And then back to simulation design is the #1 thing you need to do when you're moving online. Essentials, there's many free courses. I know in Australia, New Zealand, you have them. We have them in the States as well. And then push towards this credentialing, the certification, this cheesy certified healthcare simulation educator. I don't know, we don't have that many in Australia, but we would like more. And that really shows that you're credible, that you've gone through the certification program, and that you can also train others, other faculty. It's not going to go away soon. We're not going to go back to the way we've done it, and simulation is here to stay. So I recommend certification. And we just need to remember to take care of ourselves, our family and friends, our learners, our administrators, and our frontline workers. Do what you can where you are to decrease the spread and the anxiety associated with the pandemic. One of the fears that we have here is that people are not going to want to go into nursing. They're going to take a different profession because they're scared. Another is that everyone's going to want to become a nurse because they want to do something, but they can't get clinical placements. So we're struggling with that in terms of admitting students. How can you ethically admit students to your program when you can't assure them that they're going to have a clinical experience? And that's been a real challenge. We admitted 40 students in May of this year, and knowing we had no clinical placements for the entire summer, knowing we had none. And so the students came in and we gave them virtual sims and online sims and all of this. And they're like, when am I going to the hospital? Well, you can't. Well, why did you admit me and tell me I was going to get my hours? Well, we're going to do less hours this semester and more in the fall. And it's been very high anxiety. From an administrative perspective, you know, we need the revenue, we need to admit the students, but from you know, ethical and logistical perspective, how can we, you know, squeeze blood out of a turnip? It's just not going to happen. And so then the question is, you know, how valuable is a clinical experience? So I did a little bit of a lit review on that, and there's not much out there on the value of the clinical experience. Oftentimes our students will go into a hospital and they will expect to see maybe a CHF patient or diabetes, and that patient has either been discharged or transferred, and so they have to do something else. Maybe it's so busy that the student can only observe. Maybe it's the policy at that hospital is they can't give any medications. So all of these things can be taken care of in simulation. And so I really predict that the future is we're only going to increase our use of simulation from a mannequin all the way to the virtual over time, and that clinical experience may be saved for the end of their coursework, or it may not happen at all. I'm just throwing that out there. We just need to blow up the system and not require a certain amount of hours. We need to be outcome oriented. That's my soapbox. So this is, I would love it if you all would follow me on Twitter and LinkedIn, because I post a lot of stuff about sim, and I'd love to, you know, increase the dialogue internationally regarding simulation. So that's my presentation. I'd love to take the last time here to answer questions and chat about simulation.
KT, it's Kelly here again. Thank you so much for that. What a wonderful presentation, and a lot of similarities with the challenges that we've been having here in Australia and New Zealand. And I have a couple of questions here for you. And you did answer this to an extent, but you might want to expand on it a little bit. Georgina Willits has asked, can she clarify, are simulation hours now counted as clinical hours in nursing programs across the US?
Yes, yes. So every state is different. You can have simulation hours are considered clinical hours to the extent of that regulation. So they could do 25% per course or 25% per program or 50%, and that goes into the total hours, yes.
Fantastic, thank you. Another question we've had is, can you share a little bit about what the faculty feedback has been on virtual learning, given that it's a completely different modality, maybe some of the challenges they've had accessing the technology or feeling confident with the technology, and then secondly, maybe what the student feedback has been about that delivery as well?
Sure. Well, you know, as you know, we've got a lot of older faculty in the US, and we have a very big faculty shortage. So I would say that the faculty are not as comfortable with technology as students. I mean, that's clear, and that's always been a gap. So there have been challenges. The other thing is that we really encourage debriefing after an online module, and many of the faculty haven't been trained in debriefing or simulation to that matter. So it's been frustrating for the faculty. They're also looking for ways to evaluate it. And so there's lots of tools out there now that people are using to evaluate, because we need to make sure that the students are getting what they need. And so that's been another challenge, because like I said before, it's sort of been an add-on, and nice to have a little fluff. And now it's like part of the course. And so the faculty need to step it up. And the faculty are saying that they're working harder than they have worked, and they're very frustrated. So I think the students, in terms of the technology piece and the online, I think they really like it. it's easy for them, but they really want to get in and touch a patient. You know, that's what they really want to do. So I think there's a fine line, balance between the virtual or online, the mannequin, the SP, and then the clinical experience. So, you have to look at what your objectives are and then use the right modality to meet that objective.
Thank you. I appreciate that. KT, can you tell us a little bit? I've got a question here about the outlook for grad students in terms of jobs and placements in the US next year, given that many maybe in their final year may not have been able to complete clinical placements, what the outlook looks for those students entering the workforce next year?
Well, we have a huge nursing shortage. So the jobs are going to be there. Absolutely. They should not have trouble getting jobs. We have a shortage all over the country. Some of the urban areas, not so much because people want to live there, but in the rural areas and the smaller towns, they're desperate for nurses. We have an interesting thing that we do here in the US is that we let these students go through nursing school. And then when they get into the hospital, we put them through a 6-month to 12-month residency program. And so it's like we prepare them to take the NCLEX exam, and then they go into the hospital, and then they retrain them to do go through this residency. We're the only profession in the US in healthcare that does not have a formal residency program. The physicians, occupational therapy, PT, OT, pharmacy, everyone has that except for nursing. And so it's frustrating because we train them, we prepare them to take this exam. They're ready to go. And then the hospital retrains them to meet their needs. So what's happening is we are really forming a lot of academic service partnerships, and the chief nursing officers are getting involved with the deans and the directors in terms of curriculum development. And then the schools are working with the hospitals for workforce development, not only undergraduate brand new nurses, but taking their existing nurses and giving them higher degrees. So it's been very interesting, but all the surveys that we have done indicate that our nursing shortage is getting worse.
Oh, absolutely. And I've got another question here. I've got one before I read out David's, and it links to just what you spoke about. Around hospital orientation, do you think it will change to cope with clinical preparedness, at least in the next year or two, until maybe we return to a little bit more clinical placement for our students?
So hospital orientation, meaning new employee orientation? Is that the question?
Yes, given that they won't have spent as much time in clinical placement, I believe, from the question.
Oh, yeah. So then that probably would increase, I would think, absolutely. And I think that all hospital orientation, as well as the residency programs, need to incorporate simulation into that. And where we work with lots of hospitals to do that very thing. So I think we're going to see an uptick on the hospital side related to simulation, because the students will demand it because they went through it. And if they have to be forced into a seat to watch a PowerPoint presentation, that's not going to be good. We need to carry on with sim. So I think orientations will increase, absolutely. Residency programs will grow. And it could be that hospitals are starting to give, sign-on bonuses. This happened in the 80s and the 90s when we had our last big shortage. And so I think it's going to get worse. Hospitals are not going to be able to afford it because they've lost so much money in COVID. They lost so much money by shutting down it. I don't know about Australia, New Zealand, but when COVID hit, they canceled all of the elective surgeries. And the elective surgeries have been postponed to December. So all those people who needed a hip or a knee or, elective are going to come in during the holidays and have that work done because they cut it off. And that's their revenue source, is these electives. So that happened. The census went down in the hospitals. Some hospitals said, why we can't take any students because we don't have any patients. The only patients we have in the hospital are COVID patients, and we need our staff to take care of them. So I think hospitals are recovering, and when they need to hire nurses, they're going to have to pay and be competitive. you know, and really look at that work environment to keep people employed, because it's rough right now.
Absolutely. Thank you, Katie. I think from an elective surgery point of view, certainly in Victoria, we're in a very similar situation with surgeries pushed back. I just have one final question, and thank you to David Fulton here. Do you have any idea what is happening in medical education during COVID?
Yeah, the medical education, at least in the US, doesn't have the same regulations as we do in terms of number of hours and sim and all that. But it has been very similar to nursing in that they've done more simulation than ever before in the medical schools. We've been doing a lot of online, but a lot of that they've been doing in socially distanced manners in some of these medical schools. We have one medical school that just opened. Their grand opening was in June, right smack in the middle of all this. And they admitted 25 students, and they took a photo, and it was on Facebook, and they were all standing 6 feet apart with their lab coats, and they were all excited. But they never went online. They just admitted them in a socially distanced manner. So we have a shortage of physicians and a shortage of nurses. So I think we need to do whatever we can to get them trained. I think that nursing took a bigger hit than the medical students, though.
Thank you so much, KT. Once again, I'd really like to thank KT Waxman and all of the attendees for joining our live webinar today. We will send out an email with a link to access the recording within the next few days. And this is actually our final virtual webinar for 2020. And we would like to thank all attendees along the way since we first started these in June. We've missed seeing everybody in person, and particularly disappointed KT couldn't join us after many plans we had this year at our annual face-to-face Sun. And we hope that these can resume sometime in 2021. Please visit the Laerdal website for further information on Sun webinars and future events. Many thanks, KT. Stay safe.
Thank you, everyone. Thank you, Kelly and Sophia, so much.
Have a good day, everybody.
Thank you.